Hello, and thank you for your interest in the Methodist Mansfield Minimally Invasive Surgical Associates Introductory Lecture for Bariatric Surgery. With this seminar, you will gain a basic understanding of obesity, the risks associated with it, and a number of options available to you for achieving long-term weight loss with resolution of medical comorbidities. First, we would like to introduce you to our team. Dr. Trussell is the senior partner in our group. He is originally from Mansfield, Texas, and graduated medical school at UT Houston. His surgical training was completed at Banner Good Samaritan in Phoenix, Arizona. He was in private practice for 5 years before moving back to Mansfield. Dr. Standerwick is the junior partner who is originally from Cedar Hill, Texas. He attended medical school at UT Southwestern Medical Center, Dallas, and went to the University of Oklahoma for surgical residency. After completing residency training, he spent a year at Summa Health in Akron, Ohio, obtaining fellowship training in minimally invasive and bariatric surgery. He then joined in private practice with Dr. Trussell prior to moving to Mansfield, Texas. Obesity is a significant problem in the United States and the rest of the world. Studies completed in 2011 revealed that roughly 2/3 of Americans were either overweight or obese, with half of them being in the obese category. Texas, like much of the South, had some of the highest rates of obesity. Studies looking at rates of excess weight and obesity in school-age children show that if current rates of obesity continue, Texas alone could see 60% obesity by 2030. Fortunately, changes have been made in schools to encourage healthier food choices, which may prevent some of this from happening, but an increase in the obesity rate is still expected. Obesity is a medical condition that results from an excess of fat or adipose tissue. What we have discovered is that increasing levels of obesity tend to have increasing medical risks, so a scale is needed to estimate risk. The Body Mass Index, or BMI, is a useful tool to estimate the amount of adipose tissue in a person. The number is a result of taking one's weight in kilograms and dividing it by the square of their height in meters. Ranges of BMIs are arranged in classes, with anything less than a BMI of 18.5 kg per meter squared being underweight, 18.5 to 24.9 kg per meter squared being normal weight, 25 to 29.9 kg per meter squared being overweight, and BMIs of 30 kg per meter squared or greater beginning the obese classes. The index does have some limitations, such as not accounting for muscle mass in elite athletes and the fact that there is variability in disease presentation at any specific BMI. To review, normal BMI is the range between 18.5 and 25 kilograms per meter squared. The overweight class is between 25 and 30 kilograms per meter squared, and obesity is above 30 kilograms per meter squared. When the BMI gets above 50 kilograms per meter squared, we define that as the super obese class. This is because even greater medical risk becomes apparent. The question then becomes, how did obesity begin? What occurred to create the pathology? The general answer is that modern society provides an abundance of high-caloric, high-fat food that has never before been so cheap and easy to obtain. On top of this is the fact that our bodies work hard to avoid malnutrition by storing any excess energy it obtains. Throughout history, humans have had to worry about famine, so our bodies developed means of fighting starvation. Whenever we decide to lose weight, we often choose to follow a diet that drastically decreases our caloric intake. The result of these fad diets is that a famine response gets triggered in our bodies. The body thinks that it is starving, so hormone levels change to decrease metabolic rate and to make the body more efficient with energy. In addition, the body starts to break down muscle for energy. Any food that does not get eaten gets stored away as fat to be fuel for the long haul, and a hormone that causes the sensation of hunger, ghrelin, increases to make us more hungry. At some point, we get tired of our diet, and we try to get back to eating normally. Unfortunately, this increase in caloric intake gets viewed as a feast by our bodies. With the recent famine that the body experienced, the body makes preparations for the next famine instead of returning back to normal. Metabolic rate remains low, and energy from food still gets put away as fat instead of rebuilding muscle. The end result is that after our diet, most of us regain the weight we lost and then some in the form of fat tissue. As alluded to before, obesity, specifically the excess adipose tissue, increases the risk for developing medical conditions. This chart compares the prevalence of diseases and the mortality from all cancers in the different BMI classes. It is evident that as BMI increases, the prevalence of diabetes, asthma, arthritis, and high blood pressure increases. The risk of mortality from any cancer also increases. Recent research has revealed the strong link between obesity and the development of type 2 diabetes mellitus. Obesity is the strongest risk factor for developing this form of diabetes. Unfortunately, as this graph shows, obesity tends to cause diabetes in women at lower BMIs than in men. As we will show later on, weight loss can really impact diabetes, and in some cases, it may even cure diabetes. The inflammatory effects of obesity also cause what is called the metabolic syndrome. This is defined as having an apple shape with deposits of adipose tissue focused in the abdomen along with hypertension, hyperlipidemia, either cholesterol or triglycerides, and either prediabetes or true diabetes. If left unchecked, the metabolic syndrome can lead to vision loss, kidney dysfunction, vascular disease, heart disease, impotence, and dementia. Late stages of this disease process lead to chronic wounds, immobilization, amputations, and nursing home dependence. Obesity is directly associated with many medical conditions. It literally causes harmful effects over the entire body and in every organ system. More and more research is revealing an association between obesity and the risk of developing certain cancers. Adipose tissue normally creates estrogens, and this is believed to be the reason why obesity, with excess estrogen production, is associated with cancers of the uterus, ovary, and breast. All of the aforementioned conditions resulting from excess body weight have been shown in clinical studies to decrease quality of life, lead to undue suffering, and a decreased life expectancy. Morbidly obese adolescents who do not manage their weight successfully in adulthood will die an average decade younger than their peers who maintain a healthy body weight. And as morbidly obese adults, they will also spend as much as 44% more on health-related expenditures such as doctor visits, lab work, hospital admissions, and surgeries. The primary goal with weight loss surgery is to help you to achieve and maintain a longer, healthier, more productive life, away from the side effects, costs, and burdens of a full medicine cabinet and frequent doctor visits that come with it. Obesity is a multifactorial problem with many environmental, genetic, and behavioral contributors. So any successful treatment for obesity requires a holistic approach. The most important factor of this approach is probably our dietitians. They provide counseling to help us select a diet that minimizes fat while increasing protein intake that will result in less fat tissue while preserving muscle mass. While dietitians help treat the energy in part of the problem, physical therapists will help with the energy out part of the treatment of obesity. Healthy muscle makes hormones which will aid in further weight loss. Learning safe techniques and exercise will help prevent injury while you lose weight. Psychologists help us take care of the stress that may arise while the surgeons provide guidance in what surgery is best for you. Finally, your primary care doctor will manage your medications as your need for them decreases. Why is surgery important for the treatment of obesity? The answer is because it is the most successful at achieving long-term weight loss. In studies of weight loss medications, the best result was an 8% decrease in body weight. This required a very intense regimen of frequent follow-ups with doctors, dietitians, and physical therapists. While this amount of weight loss does lead to a significant improvement in medical conditions and decreases in doses of medications, it requires very intense therapy to maintain that level of success and does not lead to the resolution of diseases. Compare this to the results frequently achieved with Roux-en-Y gastric bypass or sleeve gastrectomy. When a patient loses 60 to 70% of excess body weight in the gastric bypass or 50 to 60% in the sleeve gastrectomy, medical conditions resolve and medications are stopped. Obesity is a multifactorial problem with many environmental, genetic, and behavioral contributors. We return to this slide to focus on the likelihood of having resolution of the common medical comorbidities of obesity. Many medical conditions are likely to resolve after the amount of weight loss that is associated with bariatric surgery. Conditions that do not resolve become much improved, and most patients come off a majority of their medications. As noted on the bottom of the image, surveys done on patients after bariatric surgery report a 95% improvement in quality of life, and studies document as much as an 89% reduction in 5-year mortality for compliant patients. All patients with a BMI over 40 qualify for bariatric surgery, as do patients with a BMI between 35 and 40 and at least one weight-related illness. Different insurance companies have different requirements for those who are in the BMI range of 35 to 40, but finding a qualifying medical condition generally is not difficult. Laparoscopy and minimally invasive surgery refer to a surgical approach that uses a high-definition fiber optic camera inserted into the abdomen through small trocars or ports, carefully placed at the initiation of the procedure. Additional ports allow working instruments to be used by the surgeons to perform the operation with video guidance. Many operations are now performed using this technology, which continues to improve and advance. It offers equivalent beneficial outcomes of traditional surgery done through larger incisions with less pain and a faster recovery. Other benefits of laparoscopy over traditional surgery include less infections, less wound healing problems, less hernias, and a significantly decreased hospital stay with much faster return to work and regular activity. Before laparoscopy, bariatric surgery was a relatively high-risk surgery because pain and wound infections prevented the early mobilization of the patient. The advent of laparoscopy nearly eliminated these issues and allowed patients to get up and walk earlier, which prevents complications. Traditional bariatric surgery has been thought of working in two ways, either by restricting the amount of food that can be consumed at any one time, or decreasing the ability of the intestines to absorb digested nutrients. Recent research continues to highlight the importance of gut hormonal changes caused by bariatric surgery that alter metabolism. The 3 most common bariatric surgeries performed in the U.S. today are the laparoscopic adjustable gastric band, or LAP band, the laparoscopic sleeve gastrectomy, or the laparoscopic Roux-en-Y gastric bypass. Because of the reasons that we will discuss, the band is falling out of favor and is not offered here. Gastric banding is completed by placing the band around the upper portion of the stomach. The inner diameter of the band is a balloon that is connected by a tube to a port that is implanted under the skin. By filling the balloon with water or saline solution, the passage of food from the upper portion of the stomach to the lower portion can be restricted. This surgery is strictly a restrictive operation. It does not alter the anatomy of the intestines to cause malabsorption, nor does it alter the gut hormones. Although it is a quick operation with very few immediate risks, gastric banding is falling out of favor in the U.S. There have been some success stories after gastric banding, but the average of 50% excess body weight loss in 3 years is matched in 1.5 years by the sleeve gastrectomy. Banding is not at all very powerful at causing the resolution of diabetes, unlike the other operations. With a foreign object remaining in the abdomen, a number of significant complications are possible, including band erosion into the stomach, leaks, and band slippage causing obstruction of the stomach. Overall, complications of the components leads to a 20 to 40% reoperation rate. Finally, there is the fact that the band wears out. Even with everything working as it should, the band is expected to require an operation to replace it in 7 years. The laparoscopic sleeve gastrectomy is the newest procedure in bariatric surgery. It began as the first step of a more complex operation, the biliopancreatic diversion with duodenal switch. It was soon discovered that sleeve gastrectomy alone is good for weight loss. It involves placing a sizing tube along the inner curve of the stomach. The tube guides the placement of a stapling and cutting device that divides the majority of the stomach away. The major portion of the stomach is completely removed from the abdomen, leaving the tubular sleeve behind that is about the size of a banana. The sleeve gastrectomy is clearly restrictive in that you cannot eat more than 1/4 to 1/2 cup of food at any one time. Interestingly, this surgery also happens to have some hormonal effects too. The hunger hormone, ghrelin, is predominantly made in the portion of the stomach that is removed. This means that patients who have had a sleeve gastrectomy tend to not feel as much hunger soon after the operation. On top of this, other gut hormones are changed that cause an increase in metabolism that results in weight loss. The anatomy of the intestines is not affected in this procedure, so malabsorption is not expected. However, taking vitamins after this operation is still recommended because the same vitamin deficiencies are seen with sleeve gastrectomy as in surgeries that are thought of as being malabsorptive. Some advantages of laparoscopic sleeve gastrectomy are that it is less complex than the Roux-en-Y gastric bypass, it offers a good amount of weight loss, 50 to 60% excess body weight loss, and it has a quick recovery. Newly diagnosed patients with mild diabetes can see a remission of their diabetes after this procedure. Disadvantages include an uncommon complication of bleeding or leakage from the long staple line that is created along the stomach. Patients with severe acid reflux should consider a gastric bypass because sleeve gastrectomy has a high risk of making it worse. Finally, the sleeve gastrectomy is a relatively new procedure. It was first done as a standalone procedure in 1993. Data is promising, but there are very few long-term studies to show what we can expect a long time after having a sleeve gastrectomy. The Roux-en-Y gastric bypass is the gold standard bariatric surgery. It was first done in 1967 as an open procedure, and later it was first done as a laparoscopic procedure in 1994. It involves dividing the stomach very close to the esophagus to make a small pouch about the size of a golf ball or an egg. Next, the small intestine is divided, and the lower portion of the small intestine is connected to the stomach pouch. Now, acid made by the larger portion of the stomach, bile from the liver, and pancreatic juices still enter into the first portion of the small intestines. Those juices need to go somewhere, so the upper portion of the small intestine is reattached to the remainder of the small intestine through a Y connection. This procedure has traditionally been thought of as only being a combination of restriction and malabsorption. Only about 1/4 cup of food can fit into the pouch. Then, that food does not start getting digested and absorbed until it meets the digestive juices at the Y connection, so it does not get completely absorbed by the time it gets to the end of the digestive tract. With the recent discoveries of the effects this surgery makes in the gut hormones, we know now that this procedure is a very powerful hormonal surgery. The hormonal effects include a decreased sense of hunger, an increased metabolic rate that burns body fat, and an increased sensitivity to insulin created by the pancreas. As stated before, this operation has been around for many years. Long-term studies consistently show that this is a very effective procedure for long-term weight loss at about 60 to 70% of excess body weight. Although some patients may eventually have to restart a diabetic medication, many achieve remission of their diabetes and never have to take another diabetic medication again. By disconnecting the acid-producing lower portion of the stomach from the esophagus, this procedure also tends to be a cure for acid reflux. Disadvantages of this surgery include the fact that it does take longer to perform than the sleeve gastrectomy. If vitamin deficiencies develop, they can be significant, so lifelong supplementation and follow-up are important after this surgery. Finally, the changes in anatomy associated with this procedure present some risks. When patients lose a large amount of weight quickly, an internal hernia can form behind where the intestines have been divided. Although the risk is about 2%, it would require a surgery to fix if it happened. Ulceration can also develop at the connection between the pouch and intestines. This happens about 10% of the time and is usually related to exposure to tobacco smoke or NSAIDs like ibuprofen. Any bariatric surgery is an abdominal surgery that has some risk. Other uncommon risks inherent to abdominal operations include, but are not limited to, bleeding, injury to other organs, pain, blood clots, infections, heart attacks, and death. There may be a perception of increased risk of mortality in bariatric surgery, but studies have shown that this is not the case. The mortality rate of 0.13% was found at high-volume centers. but when done at a low-volume center, mortality is still around 0.2%. Compare this with surgeries like the heart bypass, where a mortality of 2 to 3% is considered acceptable. Your interest in finding out more about bariatric surgery and watching this presentation is the first step to making a healthier you. While you travel along your road toward your goals, it is very important that you remember that your commitment and effort are the reasons for your success. Bariatric surgery is a powerful tool to give you a head start on weight loss, but its effects weaken over time. If good dietary and exercise habits are not learned and kept, all of the weight lost after bariatric surgery can return. Our team will guide you to those habits, but the credit is all yours when you succeed. For patients with BMIs between 25 to 35, or who are not ready for surgery, a non-surgical program is available to you that includes dietary and psychological counseling, along with physical therapy. For those who are ready for surgery, our program closely follows standards set by the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program, MBS AQIP, recommended for facilities with our size and resources. Patients with well-managed heart, lung, and kidney disease are good candidates for surgery at our facility. However, those with symptomatic heart disease, those requiring home oxygen, and those approaching the need for dialysis should be evaluated for surgery at larger facilities invested in caring for these conditions on a regular basis. Patients must have reasonable mobility and activity tolerance to be considered for bariatric surgery at our program. Smoking is still the #1 risk factor for disease and death in the U.S. There is no sense in treating obesity if the patient still smokes. In addition, smoking significantly increases risk for staple line leaks and life-threatening ulcers to form after bariatric surgery. For these reasons, patients must be tobacco-free for a minimum of 3 months to be considered for bariatric surgery. We do a blood test for nicotine to make sure patients are tobacco-free. It is okay to sign up for our program before quitting smoking, but final preparations for surgery will not be made until the patient is tobacco-free for 3 months and has a negative blood test. Which procedure is best for you depends on an individual's size, chronic medical conditions, and goals. Our staff are dedicated to aid each patient in making the most informed decision they can in regards to choosing or not choosing a bariatric procedure. Congratulations for taking the first step on the road to a new you. After completing this online seminar, you will need to log into our system and fill in your medical history and contact information. You will also need to take the online quiz offered on the website. When you pass with a score of 80% or higher, please print your certificate. This will verify you have completed the online seminar. Then we will contact you to set up an initial consultation and evaluation. If you still wish to attend a group seminar, contact our office for dates and times or locate the information on our website. For any other questions, please feel free to email or call us. Once again, thank you for your interest. Remember that our staff is dedicated to making sure you are a well-informed patient, so do not feel nervous if some of this information is confusing or has been covered too quickly. Our steps to surgery are designed not only to evaluate you, but more importantly, to educate you.